Hello, I'm Dr. Ma Liyun from Endoscopy Center at Zhongshan Hospital, affiliated to Fudan University in Shanghai. On behalf of the corresponding authors, Professor Zhou Pinghong and Li Quanling, I'm glad to spend a few minutes introducing to you our paper entitled Transesophageal Endoscopic Resection of Mediastinal Cysts, which will be published in this month's GIE journal. And on behalf of my co-authors, I'd like to thank all the staffs of GIE both for publishing our study and inviting us to participate in this author interview series. Primary mediastinal cysts are relatively uncommon lesions, accounting for 12 to 18% of all mediastinal lesions in adults. Most are embryologic in origin and congenital in nature. Radiologically, they may closely resemble other benign or malignant lesions. Furthermore, asymptomatic cysts may also occasionally cause life-threatening symptoms by infection, compression, or rupture to intrathoracic vital organs, such as the heart and trachea. Therefore, watchful waiting is discouraged. Complete surgical resection is a radical and definitive treatment, even in asymptomatic patients, to establish the diagnosis, avoid severe adverse events, and prevent malignant transform. With the development of endoscopic technology, endoscopic surgery for benign mediastinal tumors is feasible. In 2016, we firstly reported the transesophageal endoscopic mediastinal tumorectomy. Since then, we have performed this procedure for mediastinal cysts. All the procedures were performed by two proficient endoscopists, Zhou Pinghong and Xu Meidong, who have over 10 years' experience in advanced endoscopic surgery. This novel procedure combines natural orifice transnominal endoscopic surgery, in short, NOTES, and submucosal tunneling endoscopic resection, in short, STIR, which uses a submucosal tunnel to enter the mediastinal cavity. The procedure was performed with 6 steps. After mucosal incision, a submucosal tunnel was created towards the lesion. Then, full thickness myotomy was performed above the lesion, and the surrounding connective tissue was carefully dissected. Finally, the cyst was removed by a snare, and the tunnel entrance was closed by metal clips. All the procedures were performed uneventfully for 10 patients in our study, without conversion to traditional surgery. No major adverse events occurred, and no residual or recurrent lesions were observed in any patient during the follow-up period. Therefore, our results suggest that this procedure is feasible, safe, and effective for mediastinal cysts. The procedure not only allows an en bloc resection and a definitive histologic diagnosis, but is also a minimally invasive therapeutic approach that produces less post-operative pain and functional impairment. Therefore, we believe that our study represents a reasonable pilot study of clinical experience with this new technique. However, there are some limitations through the intraluminal route. For example, it is often more difficult to distinguish the relationship between the cyst and surrounding structures, as well as to determine the origin of the cyst, which may lead to accidental injury. So, this procedure is very technically demanding and requires operators to be experienced in advanced endoscopic techniques. In the future, to optimize the selection of patients for this new technique, Additional data are required to evaluate the effects of tumor size and position on the intraoperative and postoperative outcomes. Meanwhile, larger studies are necessary to systematically assess the efficacy and safety compared with traditional surgery. Thanks for your attention.